Hello. Hello. So, hello everyone. Once again here. I want to show today a very nice case. I believe will be uh, will, will be a very good illustration how to needs to be the approach and evaluation of pancreatic cystic lesion. Coincidentally, a few days ago I had to give a small lecture about this, and today I wanted to show you a little bit how I make evaluation of these lesions, because of there is a very we believe that this is not challenge. I believe this is one of the biggest challenge lesions that we need to evaluate when we are doing US. First, because we always see in a B mode. Thanks to God, nowadays we have technology and we have a lot of things that we can evaluate these lesions. Second, because of the histologic approach is difficult, also because the samples are not big, sometimes difficult, and at the same time, sometimes very with some complication in some cases, like bleeding, right? So this is one of the things, but it is necessary, because if not, we cannot give a good diagnosis, and the risk of complication after surgery could be high in non-experimental, experienced hands. So that could be from 2% to 20%, but for sure morbidity for 20%. So this is a kind of lesion that we need to evaluate very good to make a good decision and the right decision with the patients, right? So today I have this case. I want to show you first and all the B mode that you see to your left. This is the cystic lesion, right? I'm here. I will freeze the lesion, and I will make a measure of the lesion. It's a incidental lesion that was diagnosed because of this patient was with weight loss. Nothing really bad. ¿Cuántos años tiene él? So this patient is a 57 years old male with a history of some bowel disease many years ago, and right away nowadays he's smoked a lot during his life, and nowadays he has been showing lose weight. So the internal medicine physician sends to make a CT scan because he have diabetes. So and he has been little painful recently. So after that, this CT scan showed the pancreatic mass, and you are seeing this mass right away. So the mass measure 13 by 11 millimeters, right? So it means it's not a big lesion, it's less than 2 centimeters. And one of the things is what we can do with this lesion. So to evaluate it, we have nowadays this technology called DFI, detective flow imaging. It works with the Hitachi Aloka or Fujifilm right now. It means it's a very nice technology that can show you the microvascularization, right, without using contrast. So I will use contrast today because I want to evaluate both. I like to have a very good evaluation of these lesions first. I believe by DFI that these lesions have capture contrast, you see? So you see contrast here, contrast here, contrast here. This is microvascularization, to be honest. But also, you see here, I want to show you a little bit more. Here, you see here. So here is also microvascularization. So this wall completely microvascularization, have microvascularization. It means a lot. It means first that could be Uh, for sure, a cystic lesion could be a serious lesion, but by the B mode, I don't believe, just because of these small cystic areas. But normally, the serious cystic lesions doesn't have this thickness that we can see here. You see? So I'm not so sure about that if this is that. The second chance could be also a mucinous cystic lesion. I believe it's the first one, to be honest, to think about this. And the third, because of the loose weight, is just because of that. Normally, we don't have a loose weight too much with this cystic lesion. Normally, are incidental lesions, so no symptomatic. And because of that, yes, could be correlated to diabetes. Totally agree. But I believe also neuroendocrine tumors is a big chance also. So we need to understand that, and because of that, we need to make a good decision. So I will try to make a confocal right now, and then I will pass just the needle because it is difficult to have a very good biopsy from this area with the Murray because of the space that we have. So I need to have. It's like when you have one shot. That's all. So we will use confocal. Well, I need to use contrast first. Contraste, por favor. Ah, puede ser. Sí. Un momento. Un momento. ¿Ya le pusiste? Ok, dale. So we see here, now we are putting contrast. And let's see. You see? Very similar captation, very high captation, you see here? So I believe this is a neuroendocrine tumor, huh? No. You see? Very well. We can see very well. I believe a little bit much better the quality of the image from the DFI, you see? More captation. See the wall? So and then if you use DFI, I will show you something nice today. And then when you use DFI, it will increase a little bit, you see? Very similar, huh? Very good image. Okay, so now it's finished, the contrast. Still something there, but well. So now I will use my needle, 19-gauge needle with confocal. Believe is very important to evaluate inside this lesion. I know that have a very good vascularization, so right now I need to take care. But this is probably a neuroendocrine tumor. Okay. 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 So I will use one Boston needle. Retira. So now we are using a Pentax scope. The J10 series with the Hitachi Aloka. I need to be very straightforward. Okay, now I am inside. You can see very well my needle. And now le podemos pasar el okay. So now we pass fluorescein, and now I am looking inside. So confocal, okay, en grande. So very thick vessels, I believe. Yes, we have some vessels, big vessels until now. These dark areas, you see, I think it's a mucinous cysta lesion. Huh? For the characteristic, I believe it's a mucinocystic lesion. But I need to be very sure. I will take some biopsies also, however. But okay. No. So this area is very interesting and very particular. Oh, look at this. Oh wow. This is a tortuous area with vascularization. Just because of this area, I could say probably this is a serous cystic lesion, but probably this is a mixed lesion that sometimes I talk. This is very small. I am more than oh wow. However, I believe there are some areas that I see these dark clumps. I don't like it. I believe this is dysplasia, high-grade dysplasia. You see? So very beautiful image. Very beautiful image. Now on the very superficial area of the lesion, you can see very well. So you see it's very important where is the needle and the confocal, in which area, you see? Very nice. I think there are some dysplasia areas here, so that's why. So I'm very curious to see this histopathology, but to my opinion there is probably a mixed lesion here, because I am in other area from the beginning. Well, it was difficult. There were some dark clumps that could be a misunderstanding because of the blood cells. It's a high vascularization area, okay, but that because of those dark clumps, I believe it probably was a neuroendocrine tumor, also for the thickness, because in the history of this patient. But then suddenly we saw some vessels, and this this image showing us now I will push a little bit more. I want to see the epithelium, right? Yes, you see? These areas, these dark clumps, this is the area that I am little worried. And I don't believe this is a pancreatic wall. No. So this is the cystic area, I believe. I'm not so sure. Okay, now I will try to see in a different area of the cystic lesion. You can see there. So because I remember this area a little bit was had some epithelium, but at the beginning I was thinking that it was probably a mucinous, but no, it was not. And now, because of the characteristic of the lesion and the epithelium, I believe it's a mixed lesion. But there is some areas that I'm not so sure here. So we will take some biopsies, FMB. Maybe I can try to use the Murray. Yes. Okay. Perfect. So I have very nice image. Pon la imagen del. Préstame una Murray. O no, mejor así, no, sin Murray. Dame solo para aspirar. So I will make a aspiration. I don't have to chance to pass the Murray. That is very important. I said recently about that. No tanto. Necesito menos. Sí. I say today, a few days ago, that during my presentation and my lecture is that so when the cystic lesions are very small, like this one, yes, sometimes you have just one shot. It means you need to make a decision about what kind of procedure you will make on this lesion. It means, yes, for sure, if you don't have confocal, if you don't have confocal, use at least the FMB. But if you have confocal, I believe confocal needs to be the first line, because it will give you a lot of idea what is going on inside. I know that this is a very vascular lesion. I believe this could be a serious cystoadenoma, but because of the wall size and we need to make a differential diagnosis with the okay. With other lesions. So then you have to, if you have Murray, yes, it's better to use your Murray, to my opinion. Instead that we can have some bleeding risk, but we will have the same risk passing a needle. So for sure you can diminish the risk using a 22 gauge needle, but sometimes it's not enough, the tissue, and this will not be like a big situation in terms of si tenemos muestra o no. So we have very good tissue now. Yes, we have a very good tissue, huh? Okay, you see there. Okay, perfect. This is a very good tissue. I will finish my case today. Okay, it is okay. So here the lesion is still there, didn't increase nothing. So if this is a neuroendocrine tumor, is the treatment could be just because of the risk of the patient. This patient have a cardiovascular disease, I believe, also, and diabetes. So radiofrequency could be a very nice option treatment because have very good success rates of from 92 to 98% depending on the series published. But well, I didn't see anything more. For sure, this was a patient that take a lot of well, he smoked a lot, so I don't see anything. And for the moment is that I didn't see anything in the liver. So we saw the pancreas also, and the mediastinum is fine. Okay, so in general, I believe whatever it is as a lesion, I always say this is a difficult lesion to be diagnosed by B modes. B modes have less than 50% in all series when it's compared to other technologies in terms of cystic lesion diagnosis. So thank you so much and see you soon. Okay, bye.